Is reference-based pricing the cure to your company's rising health insurance costs? Welcome back to another episode of the Benefits Insider. I'm your host, Chris Hamilton, and today I want to tackle that very question. It's come up a number of times over the last week or so, meeting with employers, and it actually came up. What prompted this podcast is I saw a post by Dr. Eric Bricker, which if you don't follow Dr. Bricker, you absolutely should, because he really breaks down a lot of these concepts into a very deep level to help people understand what's really going on in healthcare, which is driving health insurance costs higher. And one of the topics that he tackled was how reference-based pricing plans worked. I want to give you my perspective as an advisor that uses reference-based pricing. In fact, it's one of the first plan types that I started working with when I got into the industry because I focus on addressing rising healthcare costs. Now, people always ask me, should we be doing reference-based pricing? And for most employers, I'm going to say the answer is no, because there are ways to get reference-based pricing results without actually going all that way. But in this episode, quickly, I want to tackle what is reference-based pricing, what's the opportunity to use it, and how would I use it as an advisor for our clients? What do I think the right way is? And reference-based pricing has evolved over the last 10 years or so. There are people that are using some of the first iterations of it, which are bumpy, but there are ways to use this effectively for the right group. Very quickly, reference-based pricing is a tool. When you're hiring an advisor, they should be showing up with a number of tools to help you solve the problem that you have. And so I picture myself, I love analogies, I picture myself walking onto a job site and there's a particular thing that needs to be built or worked on, remodeled. I need to show up with a toolkit. Some of those jobs may require me to do something like do the framing for a wall. So I'm going to use a hammer and nails for something like that. Or perhaps I need to screw in a light socket. I'm going to use a screwdriver and a screw for that. Some situations require somebody to come in with a sledgehammer and break up a concrete slab because they're going to build something in its place. And in that situation, use a sledgehammer, right? That's somewhat how I would describe reference-based pricing. It's pretty disruptive if it's not done properly. The number one thing that when people talk about reference-based pricing, they talk about balance bills. And I'm going to give you a breakdown of how the pricing works, but balance bills is one of the most common things that we hear about. I think another big problem is access. I want to break down what those are. But actually, I think what would be helpful really quick is let me give you an example of what reference-based pricing is. Let's go to the whiteboard real quick and let me share with you what it actually is. So let me give you an example to help illustrate what reference-based pricing is. Most of you watching this probably buy healthcare using a PPO insurance plan. It's the most common plan in America today. And so I want to use the example of a hip replacement on a PPO network. And so I'm in Dallas, Fort Worth, Texas. I'm going to use my area as an example. The pricing here on this axis is just directional. It's not exact, but it illustrates what I'm talking about here. It'll help you understand. Think of the big hospital in your area. This is probably true for that hospital, but using a big PPO network, picture the one that your company uses, the provider in the facility, that's the doctor, the anesthesiology, and the hospital, all told, are probably going to bill somewhere around $80,000 to $90,000 for that episode of care. But because you are a good member of big insurance company, they're going to give you a big discount. And they're probably going to discount it somewhere around that $50,000 to $60,000. So, boop, boop, boop. Big discount. You feel really good about that. This is the PPO rate. Let's just call it $55,000. That's the episode of care for that. That's using your PPO network. But if your grandpa walks into that same hospital and he's got Medicare is not going to pay that amount. They're going to pay somewhere between $15,000 and $20,000, depending on the hospital. There's different rates. Is it a teaching hospital? All that sort of thing, right? But let's just say it's going to be $18,000, okay? Pretty close, right? Well, with a reference-based pricing plan, this is important to understand, they're not starting with some highly inflated charge and then giving you down a discount off of that. They're starting from the bottom. That's the reference in reference-based pricing. The reference point is what would Medicare pay for that specific procedure? And in this case, it's a lot less than what the PPO plan would pay. But it's not likely that the hospital is going to accept Medicare from a commercial payer. So what do reference-based pricing plans do? They add a little margin on top to compensate, and sometimes it's 30%, sometimes it's 50%, sometimes it's more, but they're going to add on this additional margin, and this is going to be the reference-based price. So if you look at this, walking into big hospital, what is that? 1, 2, 3 plus, call it 300 to 3.5 times. Your commercial payers are paying 3 to 4 times more than Medicare. So what's the downside of this? Well, the first thing, most brokers, when they come to show you reference-based pricing, particularly if they're trying to win your business, they're trying to get you to switch brokers, they're going to say, employer, check this out. We're going to save you a ton of money on a lot of your claims. But what they might fail to tell you is, what do you think that hospital is going to do when a member walks in and they're used to getting paid this, but now they're being forced to accept this? Because oftentimes, those plans don't tell the hospital what they're going to get paid up front. It doesn't get determined until they get a check, and the hospital says, wait a minute, we were expecting $55K, but we only got like 22, 21. What's going on here? Well, guess where that balance is going to go? Right? Let's use this. The delta between here and here is a balance bill. Where do you think that goes? Most of the time, it's going to go to your member. Well, let's back up a second. Reference-based pricing programs will tell you that the vast majority of the time, 95 to 98% of the time, these payments get accepted by the provider, and they just write it off. There's no issue. Statistically, that is correct. But what they're throwing into that bundle is all of the physician claims. Physicians aren't where you're spending the money. Physicians are taking reference-based type payments today. It's the hospitals. And the hospitals is where you spend your money. Of this $55,000 that the PPO will pay for my hip replacement, you know how much of that is the surgeon? Like $5,000. The anesthesiologist, maybe a couple grand. The rest of this is the hospital. And that's who's getting the big shaft in this equation, which I'm not saying that's a bad thing. Hospitals oftentimes overcharge significantly compared to what reference-based pricing plans will pay, or what Medicare will pay. And this is the appeal to a lot of employers today, is how do I save this money? And that's a great question, because the solution to paying your claims this way is one of the solutions to lowering the cost of your health insurance. Because the more you pay on healthcare claims, the more you have to pay in health insurance to pay for those claims. And so this is a great strategy, particularly a decade ago when the hospitals didn't know what reference-based pricing was, and they just let people come in. You fought the balance bill, and you're actually, whenever you have to fight one of these, so statistically, right, 95 or whatever percent they're going to tell you make it through without an issue. Most of those are doctoring claims, physician claims, no big deal, right? It's the big ones, the hospital claims, the $80,000, $100,000 balance bill that they're going to want to try to fight. And that's a small percentage of the claims that you incur in a given year. So if you think about all of your claims, you're probably going to have 3 to 5% of those claims that are going to have an issue that have to be addressed. Now, the good news is that a lot of these reference-based pricing plans, there's programs and processes and procedures to address this balance bill, and we've gotten really, really good at it. So I don't really worry about balance bills. It's not going to affect your members' credit if it's done right, if you're using the right program. Let me qualify that, right? Because we put the facility on notice. Hey, this is protected under the Fair Credit Reporting Act. This bill is in dispute, and the attorneys take over and manage it. It's a pretty cumbersome process, though, when that happens, and sometimes it takes some time to get that bill resolved. But I don't really worry about balance billing as much, because guess what? The hospitals have gotten actually really smart over a decade, and they figured out that we can't win in court. So we're just going to win in the court of public opinion. And the way they do that is they say, hey, Chris, you need to come in for a hip replacement. We see that we're only going to get paid a smaller amount than what we were expecting. Pay up, give us a big check up front, and we'll give you your surgery, which most people are not going to be willing to do that. I have insurance. My insurance plan should be paying for this. So what ends up happening? They go back to the employer and they say, we're not going to see your patient. Oftentimes, I've been on the phone. I always joke about this. I joked about it in a meeting I was in yesterday with the CFO of this company. I go, it's usually the CFO that's going to have the problem, And in one case, literally a CFO was on the phone with me at one of the children's hospitals here in town and said, we're not going to see your son today to have his tonsils taken out. You don't have real insurance. We're not accepting this payment. They used, the hospital administrator used, you don't have real insurance. That was the real terminology, which is complete BS. It is real insurance. They just don't want to accept the payment. So what do? Push the member out and said, go somewhere else. Totally legal. You can do that. The only way they can legally, you can force your way into a hospital is in an emergency room with a legitimate emergency. They can't turn you away in that situation. But in that situation, the CFO and his child, who had been taken out of school, had already been prepped to have the surgery, everything ready, walking in mentally, I'm having this surgery, turned away at the door, not taking you. And that's how they win in public opinion. Guess what? That employer wanted to move back because of that specific issue. This was about 10 years ago, 8 years ago. They wanted to move back to a PPO network because they were getting those pushbacks. And that is the number one issue that we see with reference-based pricing plans doing it the old way, is that you're going to have patients that are turned away on the day of surgery. The majority of your claims will probably get processed, but the big ones, the ones where people need to have a big surgery, somebody needs to have a transplant, somebody needs to have something done at a children's hospital, somebody needs to have something done, think of a cancer treatment. The hospital realizes they're not going to get paid what they want to get paid. They're going to tell the patient to go elsewhere. And so the winning in the court of public opinion is, what do employees do when they get turned away at a hospital? They show up in the human resources department and complain about their benefits, especially if it's the owner or CFO, right? You're gonna complain that my benefits don't work. And so that's the biggest thing that we see happening, which is why I'm going to share with you, if you want to use a reference-based pricing strategy, what I think you should be doing with our clients. What we see working in today's market using reference-based pricing is what I'm about to show you right now, which is a model what we call direct contracting. And so when you think about this model of PPO versus reference-based pricing, you do see that there's a big savings opportunity here by doing this. And so what we're doing is we're coming behind to facilities that we know are friendly to us, and we say to them, hey, we're going to give you preferential treatment. We're not going to be like big PPO mega insurance company in the United States where everybody is in network. Think about this, right, from your business. If everybody's in network, what advantage do I have of being in your network other than people can access me, right? But every hospital around is just a kind of a free-for-all, go wherever you want. But if I go to a hospital and I say, you are the only one that will be in my network, and I'm going to steer my patients to you, but in exchange, I'm not paying you $55,000 for that hip replacement surgery. I'm going to pay you a fair rate that's based off of some percentage of Medicare. And as you can tell, it's significantly lower. There's a big delta here between PPO and this. This is the savings potential, but patients don't get turned away. In fact, they're welcomed with open arms. And oftentimes, this facility, we make, I don't like to use the word free, so I'm going to put it into air quotes, but we make this free to the member. There's no such thing as a free lunch. Dr. Winters, I remember that from Econ 101. No such thing as a free lunch. The employer is still paying the claim. The employee is getting it at no cost, but the reason why is because of this big savings delta here. Without the potential for balance billing, members able to access care, it's already pre-vetted, pre-priced, they're welcome with open arms. And so this is where we see this happening today. If people do not want to go to a direct contracted facility, that's great. We layer in a reference-based pricing plan, go wherever you want, which can also be somewhat of a rub. So there's a few different ways that you can solve that, and I want to share that with you now. Okay, so we talked about direct contracting as an alternative or a next iteration of using reference-based pricing, but there are several other important components that you want to consider when looking at moving to a reference-based type plan to eliminate the noise that I mentioned. Access to care, the potential for balanced bills. Number one is going to be having direct primary care. And these are independent physicians. I've done an episode on direct primary care. You should check it out. But these are physicians that don't work for insurance companies. They're independent. They have much lower caseloads. They're able to develop personalized relationships with your employees, understand all of their health needs. But the most important thing that we're relying on direct primary care for is that early intervention and steering patients to the most effective or through the plan that we've built. The second thing that is important. And some DPC, some of the larger, more established, integrated direct primary care programs have this, which is a care coordination component. And that's where they have clinical staff that sits above the practicing physician. And these clinicians are designed to be able to get patients into the right hospital at the right time at the right price. So we have a direct contract, and sometimes a patient, that's the right hospital or the right facility for them to go to, and so we send them there. But periodically, you'll run into a situation where that one direct contracted facility may not be the best thing for this particular episode of care, or maybe a patient doesn't want to go to that facility and they want to go somewhere else. That's where this clinical team is able to negotiate a one-off agreement to get a patient into the hospital of their choice. So the third component of direct primary care and care coordination is a payment mechanism. We need a way to pay for that. And it needs to be paid at the time of service because these members are going in and paying cash. And so the most common way that we're doing that now is through the integration of virtual payments. It's basically like if you use Apple, it's your Apple Wallet. It's giving a virtual debit card. We've paid for things such as baby birth, maternity care, joint replacements. The biggest thing I've seen that we've paid with a virtual payment card, no kidding, is a brain surgery. About $175,000 paid in cash at the time of the surgery down in Houston. And patient walks in with their Apple phone and they pay for it. And it was a fraction of the price that it would have gone through. It was 4 times less expensive doing that than it would have been had they used the PPO network, which is crazy to think about that. But there's big savings to be had using that sort of program. Member was able to go to a center of excellence to get their care at a fraction of the cost that normally would have been billed. So the direct primary care, having a coordination team. Sometimes if you're not using direct primary care, there are other care coordination programs that are out there to help navigate your members to where they need to go. That's a really important component to this because healthcare and health insurance is complicated. Most people, they're working, they're trying to figure out how to put food on the table, get their kids to soccer practice, do their job, handle their chores. The whole healthcare thing, sometimes it can be a nightmare for people to try to navigate. That's why giving them experts at their time of need to help them coordinate where they need to go, making sure they're able to get the right price. The reason why the right price is important for them are clients that are winning this, and this is something you should consider. If they'll go through these channels to do this, we make their healthcare at no cost. It's free to them. We waive their deductibles, we waive their copays, out-of-pocket costs. They're literally going to facilities, getting major expensive things at no cost. And the reason why, as I illustrated just a few minutes ago, is the cost savings to you, the employer, is so high that we want to share in that reward and help your employees at the same time. It's how you're able to provide more benefits, but save money at the same time. It's a win-win-win situation because the facilities are happy to take these people. They're getting volume. The last component of this that's going to be really important is to ensure that your advisor is able to support your members, and that's going to be through education, not just at open enrollment, but ongoing throughout the plan year. That's either via text message, phone, video, educational, being able to remind people what their benefits are throughout the year. The last component of that, which kind of ties into it, is making sure they have advocates on staff to take your calls, your employees' calls. Because periodically people will have questions. They'll forget how the benefits work. And it's just good to be able to provide something other than a 1-800 number for your employees to call to get a hold of an expert to handle what needs to be handled at that time. So I hope these tips are helpful. Hope it explains what reference-based pricing is. I'm not saying reference-based pricing is bad. I think it's a valuable tool if used in the right situation with the right companies. And depending on where you're located, reference-based pricing may be more feasible than others. It can be used anywhere, but you want to make sure that you're putting in the right components to help reduce that friction and noise. And there are ways to do that make reference-based pricing palatable and easier for employers and employees. But it all comes down to how that plan is designed. Not everybody's doing it the right way or the best way. That's why if you're looking at doing something like this, it's important to get a second opinion. If that's something you're interested, send me a note. I'm happy to share what we're doing specifically, whether that's the vendors that we're using, the administrators, the specific programming. But I hope this was helpful to you, and I hope it's able to put more profitability to your bottom line and more money in your employees' paychecks. But until next time, take care.